you might have seen the slides which earlier I uploaded, but unfortunately the sound quality was very poor. Today we are going to start with the tumors of the liver. The tumors of the liver, as you all know, the tumor everywhere, they are divided into two types. Either they are benign tumors or they are malignant tumors. There are different tumor-like lesions which are found in the liver, and among these, the different nodules, for example, the focal nodular hyperplasia, regenerative nodular hyperplasia, these are two important conditions which arise because of a number of causes, which I am going to tell you in a while. The benign tumors, the liver cell adenoma, which is very common in the females, and the hemangioma, which is one of the most common benign lesions of the tumor. Liver. The hemangioma, this is the most common benign tumor. It is single. Normally, size is 1 to 4 centimeter, round or wedge shaped, dark red in color, honeycomb appearance on fibrous capsule, and you all may be familiar what is the name, the hemangioma. This is composed of plump vascular channels which are grouped together spaces and they are lined by flat endothelial cells. The focal nodular hyperplasia, this presents usually in the form of nodules in the liver. The basic importance of this lies in that it is normally found in the females of reproductive age. Sometimes it may be mistaken for the tumor, number one, and if they are found just beneath the liver capsule, they may rupture, they may they may cause severe pain. So this sort of conditions may arise. This is usually a well demarcated nodule with a central stellate scar, and it is normally the hepatocytes are arranged around that stellate scar, and they're normal looking hepatocytes. Plus there is lymphocytic infiltrate as well. The regenerative nodular hyperplasia, as the name implies, this is the formation of regenerative nodules. They may be in a number of conditions. Normally, histologically, they are appreciated as spherical nodules, plump hepatocytes rimmed by atrophic cells. Their association with the connective tissue disorders, for example, the rheumatoid arthritis, Feltis syndrome, and the excessive use of anabolic steroid. So this may be the etiology of these regenerative nodular hyperplasia because of the cell death of the hepatocytes. There is a regeneration, and this regeneration doesn't follow the normal norms, but it is not normally rimmed by the fibrous tissue. As you recall that for the diagnosis of cirrhosis, we must have three conditions: the formation of regenerative nodules, the formation of the fibrous tissue, and total lobular disarray. But one thing which is very important, that this regenerative nodular hyperplasia can lead to portal hypertension. Hepatic adenoma, this is again a very important benign tumor. It is associated with different sort of genetic alterations, rather alteration in the genome, that is the HNF1 alpha inactivated adenomas with virtually no risk of malignant transformation. They are often associated with the use of oral contraceptives, and the MODY 3, if when we will discuss the uh, diabetes mellitus, we will read about that. This is a monogenic form of diabetes, so they may be associated with that. The beta-catenin activated adenomas, or the mutation of beta-catenin genes, these are associated with very high risk of malignant transformation. There is deficiency of the enzyme glutamine synthetase. Diffusely positive is there. I repeat once again, in fact I've spoken wrong. The glutamine synthetase diffusely positive in these cells. The inflammatory adenoma, these are the hallmark of which is upregulation of CRP and serum amylin, which means that there is increased amount of these two acute phase reactant in the blood of the patient. Hepatocellular adenoma, if somebody asks about the morphological features or histological features, normally they are well circumscribed masses with, and on cut section we make slides of that. Can see these sheets and cords of cells having clear cytoplasm due to high glycogen content, and this is usually associated with the use of the oral contraceptives. Malignant tumors, they may be divided into three. The most important among them is the hepatocellular carcinoma, and then there is hepatoblastoma, and finally the cholangiocarcinoma. As the name implies, the hepatocellular carcinoma, it arises from the basically the hepatic parenchyma, the liver tissue itself, which includes the hepatocytes. Hepatoblastoma, this is a tumor, primitive tumor you can say. It is it shows all the features of the original, as you can see from the name of the blastoma, that the cells, they resemble or they have got marked tumor anaplasia in some conditions. Cholangiocarcinoma, this sort of tumor, and hepatoblastoma is found usually in the children, younger age, very younger age group. Cholangiocarcinoma, this, as the name implies, arises from the cholangioles. The cholangioles are the small bile ducts in the inside or outside the liver, but when it is inside the liver, it may be confused with the hepatocellular. The cantilever tumors, this accounts for a number of the tumors of the liver which may be mistaken for the primary one. The metastasis from the gastrointestinal tract are very common. Breast and bronchus, involvement in the lymphoma and leukemias. So whenever you are asked about to write down about the tumors of the liver, you must first describe that the liver may have two sorts of the tumor. One, those which are because of the metastasis, and the primary tumors of the liver. And those arising because of the metastasis, they are most commonly from the gastrointestinal tract, breast and bronchus, and they may be that the liver is also involved in case of lymphoma and leukemias. What is the hepatocellular carcinoma? Its incidence, its prevalence. One of the most common visceral tumor. The males are affected more than females. The male to female ratio is about 3 to 1 and 8 to 1 depending upon area. For example, in the areas where the hepatitis B viral infection is endemic, for example the Mozambique and areas like that, in China, etc., where they consume the stored peanuts, where there is aflatoxin produced from because of the infection by or infestation by the fungus. That area has got a high incidence of the hepatocellular carcinoma. Factors which predispose to hepatocellular carcinoma, which are most important, the hepatocellular carcinoma, usually one thing which I forget to tell, it affects older age group, the age group in the 50s or 60s, though there are younger people which are involved as well, especially those who acquired the infection earlier. For example, if there is vertical transmission of the HBV genome, it gets integrated into the host genome, and there are higher chances of the hepatocellular carcinoma. Similarly, the viral infections, toxic injuries, aflatoxin, which is produced by the Aspergillus species, the different genetic conditions which we shall talk about, the hemochromatosis, alpha-1 antitrypsin deficiency, they also enhance the risk of hepatocellular carcinoma. And in viral infections and in these conditions, the common factor is usually the repeated bouts of cell death, regeneration, as the process of inflammation and regeneration is going on. So they may acquire such sort of mutation which can lead to the formation of this hepatocellular carcinoma. Genetic alteration, as we saw in case of the liver cell adenoma, the activation of beta-catenin and inactivation of p53, which is also known as the guardian of the genome, are two most common mutations identified almost in 40% of the persons with hepatocellular carcinoma. The precursor lesions of hepatocellular carcinoma, as you must have read in case of when you were taught about the female genital tract, the development of the squamous cell carcinoma of the cervix, that it goes through certain changes. The changes which are normally thought to be pre-malignant. For example, the dysplastic changes, what means that cells they become dysplastic, there's increase in the pleomorphism, high NC ratio. Such sort of changes may be seen in the liver as well. These changes have been seen in the form of small cell change thought to be pre-malignant. What happens is that when you see the biopsy is done in patients with the cirrhosis of liver, especially those who have got advanced liver disease, you may see the cells which actually appear smaller than the hepatocytes. Their nuclear size, however, is large as compared to the amount of the cytoplasm. So there is high NC ratio. The large cell change, this in fact is again a potential indicator of the here it is most likely a topographic mistake. The large cell change is normally not the potential indicator of malignancy, though it may, but these cells they have got an almost equal amount of or almost the proportionate amount of the nucleus and the cytoplasm, and they are normally found because of the fusion of the different cells when the regeneration is there. The dysplastic nodule, this is low grade dysplastic nodule and high grade dysplastic nodule, as the name implies that in these nodular lesions you may find dysplasia of the cells in the form of increased pleomorphism, increased NC ratio. You may see irregular mitotic figure or irregular mitotic activity as well. Morphology of the hepatocellular carcinoma, if we talk about it, the gross morphology, it is normally in three forms. Either there is a single expanding lesion, or it may be a multifocal or infiltrative. What is meant by single lesion? You may see single large yellow brown large mass with central necrosis, hemorrhage, and it is rarely bile stained as well. These tumors are bile stained. You must remember to differentiate it from the cholangiocarcinomas. The cholangiocarcinomas are not bile stained. The reason being, often you should remember that the hepatocytes they are engaged in the function of formation of the bile, so they may be bile stained. While the cholangiocarcinoma, the cholangioles, they are only the conduits or the channels which transmit the bile from the liver. The multifocal lesions, you may see the multiple lesions which are scattered throughout the liver. Infiltrative, this is a diffuse form in which it would permeate entire of the liver in a diffuse form. So these are the three gross features of the hepatocellular carcinoma, that is the expanding or unifocal lesion, multifocal lesion, or it may be infiltrative lesion. I want to select this color. So you can see here, this is the hole which is I am trying to encircle. This is the hole of the lesion here, which has been encircled by this red arrow. Now, what are the histological features? The histological features are, again, it may form any of the either of these forms. That may be trabecular, that may be pseudoglandular, that may be compact pattern, that may be scirrhous, or even you may find solid sheets of the hepatocytes. Trabecular, as the name implies, here you would see the trabeculae, and these trabeculae they are much more thicker, composed of cells which have got all the features of malignancy. For example, high NC ratio, nuclear pleomorphism is there, and irregular mitotic activity may be there. Pseudoglandular, as the lesion is arising from the epithelium, so there may be formation of small gland-like structures. The compact pattern, what is meant by that? That in this pattern you would see the compact sheets of the hepatocytes which are irregular in shape and size, and they are composed again of the malignant cell scirrhus, that it may invoke a scirrhus response or fibrous response, and in between these fibrous septa or the bands you may see the foci of the hepatocytes, malignant hepatocytes. The trabecular pattern is one of the most common. The cytological features, the cells they resemble with hepatocytes in the well differentiated one. In the poorly differentiated they may not be quite similar, and they have got large vesicular nuclei, prominent nuclei, cytoplasm is eosinophilic and granular tumor giant cells may be seen. And finally, the clear cell variant, this is the one because of the high content of glycogen in the cells which gets cleared off while in the process of processing these for the histopathology, so they appear as clear cells. Here you can see here morphology, histological appearance of this tumor. This is in fact you can see that quite in the form of a sheet of cells. A sheet of cells you can see here the cells they appear quite irregular. Some are larger, some are smaller, some have got prominent nuclei in them. The nuclei are appearing irregular in shape and size. This is the trabecular pattern, but the trabeculae what you are going to appreciate here is they are much more thicker as compared to the normal trabeculae of the liver. The spaces here, these are the vascular spaces, vascular channels which can be seen here. These are the vascular channels in between these large trabeculae. The glandular pattern you can see here on the left side of this slide. These are the glandular structures formed. So these are the different histologies of that hepatocellular carcinoma. The metastasis, it is usually to the regional lymph nodes, the perihilar, peripancreatic and periaortic, and to the lungs late in the course of the disease. The lab diagnosis, one of the most important tumor markers is the alpha-fetoprotein, which may show sudden rise. Though the alpha-fetoprotein may be found in the advanced cases of cirrhosis of liver, it is raised, but is not so much raised as is in case of the hepatocellular carcinoma. The production of ectopic hormones like erythropoietin can lead to secondary polycythemia, and insulin factor may be seen. Parathyroid hormone related protein hypercalcemia may be there, but you must remember that the alpha fetoprotein is one of the most important tests which is normally done. Now coming to another variety of the which is rarer, involves the younger people, and this is known as the fibrolamellar variety. The fibrolamellar hepatocellular carcinoma or fibrolamellar carcinoma, uncommon malignant neoplasm of the liver, that it has got distinctive clinical and histological and radiographic features. Compared with hepatocellular carcinoma, fibrolamellar carcinoma occurs in a younger population and is typically not associated with underlying liver disease. The hepatocellular carcinoma is in most of the cases is associated with underlying liver disease. That may be because of the cirrhosis which is there, because in case of the post-viral, for example, the HBV infection, HCV infection, hematochromosis, etc. But the fibrolamellar carcinoma is not associated with the underlying liver disease or elevated serum levels of alpha-fetoprotein. Also, fibrolamellar carcinoma may have a slightly better prognosis as compared to the hepatocellular carcinoma. Here you can see the picture and this small description of that. You can see the gross picture of the liver. There is a central, as I told you, that the focal nodular hyperplasia, which is also in the form of a central scar from which radiating the cords, and around that are the hepatocytes. Similarly, you can see here in fibrolamellar carcinoma, the picture is almost similar. Here in this, on the right side is the liver, showing you this is the central scar, this one which I am now encircling, and around that are the cords of the cells, while on the left side you can see the islands of the cells which are encircled in this fibrolamellar tissue which I am now encircling. This you can see here the areas which are appearing less you can say pinkish, while those areas, these are these areas of the cells. The cells, they are normally round to polygonal, or they may be in the form of cords, and next they are separated by the fibrolamellar tissue. So the histological features of the you can say the fibrolamellar carcinoma, they are arranged in the form of solid sheets of the cells. These sheets, they are separated by the fibrolamellar tissue. Metastasis again is to the regional lymph nodes. Metastases are found in 50 to 70% of patients at the time of initial diagnosis. Now coming towards the hepatoblastoma, a small description was essential to make you familiar with that. This is a childhood tumor. Usual presentation is before of the age of 2 to 3. The different types of it are the epithelial type, which is composed mostly of the small polygonal cells which are arranged in the irregular cords and sheets, and it resembles the liver. The mixed epithelial and the mesenchymal type, as the name implies, it is composed of the epithelial structures and as well as the mesenchymal structure. You can see here I am going to encircle. This is the mesenchymal portion, the one, and this is the portion, epithelial portion. So it is composed of two portions. The cholangiocarcinoma, this is a malignancy of basically the biliary tree arising from within the liver or outside. But when it involves the liver or it arises in the liver, so it may mimic or it may be confused with the hepatocellular carcinoma. So very briefly, what are the risk factors which include the chronic inflammation and cholestasis, especially the ascending cholangitis or the sclerosing cholangitis, the liver fluke infestation, and the repeated exposure to the thorotrast, the dye used in the studies of the liver. The location and morphology, normally intrahepatic or extrahepatic, 50 to 60% are the perihilar, and 20-30% are distal, and 10% are the intrahepatic. So these are these 10% variants which can be confused with the hepatocellular carcinoma. But remember, there are features which differentiate it from the basically the hepatocellular carcinoma. One feature I've already told you, that these cholangiocarcinoma, they are not bile stained tumors. Morphology, you can see here, they may appear on gross appearance. The appearance is of, you can see the liver is, whole liver is studded with small tan yellow nodules, and the areas of necrosis is there. And if we see the histology, you can see the small tubular structures. This is the surrounded by the desmoplastic tissue. These are the two important features. The cell lining, this show high NC ratio and marked cellular pleomorphism. So this is the histological picture of the cholangiocarcinoma. Again, you can see a high power view of the cholangiocarcinoma. Similarly, these ductule like structures, they are surrounded by the fibrous tissue here,